Hello, I'm Rachel Henry, student number 2004-25-120, and this is my critique video. For the health assessment portion of this critique, I was given acute myocardial infarction, which is also known as a heart attack. And this occurs as a result of sustained ischemia causing irreversible myocardial cell death. And in almost all acute myocardial infarctions, which is almost 80 to 90%, they occur due to thrombus formation. For subjective questions, I would first ask about chest discomfort, such as pressure, squeezing, pain, burning, or heaviness. Then, if yes, I would move into the OPQRSTUV, so the onset, how long have you been experiencing this pain? P, provoking, is there anything that makes the pain worse or better? Quality, can you describe the pain? Is it a squeezing, burning, throbbing, heaviness? Region and radiation, do you feel your pain anywhere else, such as your neck, jaw, shoulder, arms, or back? Pain in those parts of the body accompanied with the other symptoms are usually a sign of a myocardial infarction. Severity, what is your pain on a scale of 0 to 10? Time, is there any time in the day that makes the pain better or worse? And understanding, what do you think is causing the pain? I would ask about shortness of breath and coughing. Have you been experiencing any shortness of breath, troubles breathing, or coughing lately? Nausea and vomiting. Have you experienced any nausea or vomiting since your symptoms began? Blood pressure and heart rate. First, I would ask if they know their normal blood pressure and heart rate, because blood pressure and heart rate may be initially increased with a myocardial infarction, and then blood pressure may drop later because of decreased output. I would ask about a fever. Since the problem started, have they noticed if they've been feeling feverish or if they've had a temperature greater than 38 degrees? Then I would ask mental status. Have you been experiencing more than normal dizziness or confusing? And fatigue, if they seem more tired lately than normal. For inspection of a patient who may be having a myocardial infarction, the nurse would look for cyanosis or pallor, so blue or ashen skin. She may find diaphoresis, as well as jugular venous distension, peripheral edema. The patient may be experiencing anxiety, and you may find them clutching their chest due to chest pain. A set of vitals may indicate tachycardia, hypertension, atrial fibrillation, or ventricular arrhythmia, and you may also find the patient wheezing. There is no percussion needed in the assessment for somebody that may be having an acute myocardial infarction. During palpation of somebody who may have a myocardial infarction, the nurse may find the patient's skin to be clammy and cool to the touch. She may find that the jugular vein is distended, and although it is rare, there may be chest tenderness. During auscultation of somebody that may have a myocardial infarction, over the lungs you may hear crackles and wheezes, and during a cardiac assessment you may hear distant heart sounds, splitting S2 heart sounds. When listening over the apex, you could hear S3 and S4 sounds, which may indicate a ventricular dysfunction, and a loud hollow systolic murmur may indicate a septal defect or mitral valve dysfunction. The signs and symptoms of a heart attack may be different in women than in men. Women can experience a heart attack without any chest pressure. They may experience shortness of breath, pressure or pain in the upper abdomen or lower chest, dizziness, lightheadedness, or fainting, upper back pressure, or extreme fatigue. Indications for chest tube insertion include pneumothorax, which can be caused by trauma, surgery, invasive pulmonary procedures, forceful coughing, or procedures such as central line insertion, and the tube would be placed anteriorly near the apex of the affected lung at the second intercostal space, mid-clavicula line, and then hemothorax is also an indication, which can be caused by open chest procedures or blunt penetrating trauma, and the two chest tubes may be inserted, one at the apex and one at the base of the lung, and also pleural effusion, which can be caused by heart failure, surgery, or malignancy, and the tube would be placed posteriorly into the fifth or sixth intercostal space. Pneumothorax is the collapse of lung tissue caused by a collection of air in the pleural space and a loss of negative intrapleural pressure. An open pneumothorax results from external injury through the chest wall and into the pleural space, such as penetrating chest trauma. A closed pneumothorax results without external injury. And a tension pneumothorax is when air can enter the pleural space but cannot escape the same route of entry, and the content of the mediastinum shift to the opposite unaffected side of the chest. A hemothorax is the presence of blood in the pleural space, which results in partial or complete collapse of the lung, and is usually a result of trauma, but can also be caused by rupture of the small blood vessels from inflammatory processes such as pneumonia or TB. For care of somebody with the chest tube, the nurse will perform hand hygiene and assess the patient's pulmonary status, vital signs, SpO2, and level of orientation and pain. The nurse will observe the chest tube dressing and sites surrounding the tube insertion, observe the tubing for kinks, dependent loops, or clots, and the chest drainage system, which should be upright and below the level of tube insertion. The nurse will provide 2 shotted hemostats or approved clamps for each chest tube attached to the top of the patient's bed with adhesive tape. The nurse will position the patient either in semi-Fowler's to high Fowler's position to evacuate air in the pneumothorax, or high Fowler's position to drain fluid in hemothorax or effusion. The nurse will maintain tube connection between the chest and drainage tubes and ensure that it is intact and secure. The nurse will coil excess drainage tubing on a mattress or chair and secure with a rubber band, safety pin, or plastic clamp, and leave enough space for the patient to move. The nurse will adjust tubing to hang it in a straight line from the top of the mattress to the drainage chamber, and if the chest tube is draining fluid, indicate the time on the drainage system with adhesive tape or write on a surface. The nurse will then perform hand hygiene again and evaluate the patient's vital signs, the chest tube dressing, the tubing, the chest drainage system, the water seal for fluctuations with the patient's inspiration and expiration, the waterless system for bubbling and the suction control, and the type and amount of fluid drainage, and note the color and amount of drainage. She will observe the patient for decreased respiratory distress and chest pain and auscultate the lung sounds. And she will ask the patient to evaluate their pain on a scale of 0 to 10. Unexpected outcomes for chest tubes include continuous bubbling in the water seal chamber. This indicates a leak between the patient and water seal. Assess all connections between the patient and drainage system and tighten any loose connections. Check institution policy. If instructed, cross-clamp tube close to patient's chest. If the bubbling stops, the air leak is inside the patient's thorax or at the chest tube insertion site. Unclamp tube and notify healthcare provider immediately. Reinforce chest dressing. Leaving a chest tube clamped causes a tension pneumothorax and mediastinal shift. Another is chest tube is dislodged. Immediately apply pressure over the chest tube insertion site and have assistant apply occlusive gauze dressing and tape 3 sides. Notify healthcare provider. Tension pneumothorax is another unexpected outcome. Determine that chest tubes are not clamped, kinked, or occluded. Obstructed chest tubes trap air in the interpleural space when an air leak originates within the patient. Notify healthcare provider immediately and prepare immediately for another chest tube insertion. Obtain a flutter valve or large gauge needle and short-term emergency release air in the intrapleural space. Have emergency equipment such as oxygen and coke cart near patient. Another is substantial increase in right blood drainage. To take care of this, obtain vital signs and monitor drainage and assess the patient's cardiopulmonary status and notify the healthcare provider. The last unexpected outcome is the sudden cessation of chest tube drainage. To take care of this, observe for a kink or possible clot in the chest tube drainage system and assess for mediastinal shift or respiratory distress and notify healthcare provider. Thank you for watching.